Pain is a universal experience, but not all pain is the same. The International Association for the Study of Pain, or IASB, classifies pain into three main types: nociceptive pain, neuropathic pain, and nociplastic pain. Each type has unique origins and mechanisms. Nociceptive pain arises from actual or threatened damage to non-neural tissue. Neuropathic pain is caused by a lesion or disease of the nervous system, and nociplastic pain is due to altered nociception without clear evidence of tissue damage or nerve disease. This classification aims to help clinicians better understand and treat pain, but as we'll see, it also introduces new complexities and challenges. Nociplastic pain, or NPP, is a relatively new concept in pain medicine. Unlike nociceptive or neuropathic pain, NPP is defined by the absence of clear tissue damage or nerve lesions. This makes it particularly difficult to diagnose. Patients with nociplastic pain often experience hypersensitivity and spontaneous pain, symptoms that overlap significantly with neuropathic pain. Because of these similarities, distinguishing between NPP and neuropathic pain in clinical practice is challenging. The lack of reliable diagnostic tools further complicates matters, leaving both patients and clinicians searching for answers. IASB's classification system was designed to clarify the mechanisms behind different types of pain. Nociceptive pain is typically straightforward, linked to injury or inflammation. Neuropathic pain, on the other hand, is associated with nerve damage or disease. Nociplastic pain, however, is defined by exclusion, pain that cannot be explained by tissue damage or nerve lesions. This approach, while theoretically useful, has led to significant ambiguity in both research and clinical setting. As diagnostic technology advances, the boundaries between these categories may shift, further complicating the landscape. Terminology and definitions for pain types have evolved over the years. In 1994, neuropathic pain was defined as pain caused by primary lesion or dysfunction in the nervous system. Nociceptive pain was formally defined in 2001. The term nociplastic pain was only introduced and adopted by IASB in 2017. This evolving language reflects our growing understanding of pain, but it also means that older research may use terms differently than current standards. This can create confusion when interpreting studies or comparing treatment outcomes across time. Better understand these categories, let's look at some common examples. Nociceptive pain includes conditions like osteoarthritis, rheumatoid arthritis, and post-traumatic pain. Neuropathic pain is seen in radiculopathy, diabetic neuropathy, and postherpetic neuralgia. Nociplastic pain is often associated with fibromyalgia, chronic back pain, and chronic temporomandibular pain disorders. These examples highlight the diversity of pain experiences and the importance of accurate classification for effective treatment. Diagnosing different types of pain relies on several methods. For neuropathic and nociplastic pain, clinicians use the IASB definitions, grading systems, questionnaires, and objective diagnostic tests. However, each method has its own limitations. For instance, questionnaires and grading systems were developed before nociplastic pain was officially recognized, so they may not accurately distinguish between NPP and neuropathic pain. Objective tests like imaging and biopsies can identify nerve lesions but often fail to clarify the underlying pain mechanism in many cases. Grading system for pain, developed by experts and supported by the IASB, attempts to standardize diagnosis. For neuropathic pain, the system requires evidence of a lesion or disease affecting the nervous system. For nociplastic pain, the grading is less clear. Currently, only possible or probable NPP can be diagnosed with no criteria for a definite diagnosis. This lack of clarity means that many patients fall into gray areas, making treatment decisions more complicated. Pain questionnaires like the LANSS, Pain Detect, and DN4 were designed to identify neuropathic pain. However, these tools were developed before nociplastic pain was officially recognized. As a result, they may misclassify patients with nociplastic pain as having neuropathic pain. Studies have shown that these questionnaires often fail to distinguish between pure nociceptive, neuropathic, and nociplastic pain, especially in complex conditions like osteoarthritis. This highlights the need for updated diagnostic tools. Objective diagnostic methods, such as quantitative sensory testing, neurophysiology, and imaging, are valuable for identifying neuropathic pain. However, these tests have limited utility in distinguishing nociplastic pain from neuropathic pain. No validated biomarkers currently exist for nociplastic pain, and even advanced imaging often cannot differentiate between pain types. This diagnostic gap underscores the challenges clinicians face when trying to provide targeted treatment. Practice, nociplastic and neuropathic pain often present with similar symptoms. Both can involve hypersensitivity, spontaneous pain, and overlapping treatment responses. For example, fibromyalgia, a classic nociplastic pain condition, shares many features with neuropathic pain and is often classified as such by existing questionnaires. This clinical overlap makes it difficult to draw clear boundaries between the two, raising questions about the value of maintaining separate categories. Fibromyalgia is frequently cited as the prototypical example of nociplastic pain. However, research shows that many patients with fibromyalgia also meet criteria for neuropathic pain, especially when using standard questionnaires. Studies have found that small fiber neuropathy, a hallmark of neuropathic pain, is common in fibromyalgia. This suggests that the distinction between nociplastic and neuropathic pain may be more theoretical than practical, at least for some conditions. When it comes to treatment, the lines between nociplastic and neuropathic pain blur even further. Both types often respond to similar medications, such as antidepressants and gabapentinoids, as well as non-pharmacological interventions like exercise and cognitive behavioral therapy. There are no established guidelines that clearly separate treatments for nociplastic pain from those for neuropathic pain. This practical overlap supports the idea of integrating the two categories for clinical purposes. Coexistence of unified and separate concepts of neuropathic pain has led to academic ambiguity. Before 2017, the term neuropathic pain often included what we now call nociplastic pain. After 2017, the definitions diverged, but many studies still use the terms inconsistently. This makes it difficult to compare research findings or develop clear clinical guidelines. The confusion is compounded by the use of different diagnostic criteria across studies. Because there is no gold standard diagnostic method for nociplastic pain, clinicians must rely on exclusion and subjective judgment. This introduces significant uncertainty into both diagnosis and treatment. The lack of clear boundaries means that patients may be misclassified, and research findings may not be directly comparable. This uncertainty is particularly problematic for non-specialist clinicians, who may struggle to navigate the complex landscape of pain classification. Central Sensitization Inventory, or CSI, is a self-report tool used to assess symptoms related to central sensitization, a process thought to underlie both neuropathic and nociplastic pain. CSI score of 40 or higher is often used as a diagnostic criterion for central sensitization syndrome, which includes fibromyalgia. However, the CSI does not reliably distinguish between nociplastic and neuropathic pain, further highlighting the overlap between these categories. Assessing pain in children and adolescents presents unique challenges. Many pain assessment tools have limited validation in younger populations. While quantitative sensory testing and self-report questionnaires show some promise, their ability to distinguish between nociceptive, neuropathic, and nociplastic pain in children remains uncertain. This highlights the need for age-appropriate diagnostic tools and further research in pediatric pain management. Recent research suggests that many chronic pain conditions involve overlapping mechanisms. For example, osteoarthritis, traditionally considered nociceptive, often shows features of neuropathic and nociplastic pain. Central sensitization is common in chronic pain disorders, blurring the lines between categories. This mechanistic overlap supports the argument for a more integrated approach to pain classification and management. For clinicians, especially those who are not pain specialists, the current classification system can be overwhelming. Pain can be classified into 7 categories based on combinations of nociceptive, neuropathic, and nociplastic mechanisms. However, clear treatment strategies for each category are lacking. This complexity can hinder effective care and may discourage non-specialist clinicians from engaging in pain management. Distinguishing between nociceptive and neuropathic pain is important because they require different treatments. However, the distinction between neuropathic and nociplastic pain is less clinically relevant, as their treatments largely overlap. For example, both respond to antidepressants and gabapentinoids, and non-pharmacological therapies like exercise and cognitive behavioral therapy. This practical similarity further supports the case for integrating nociplastic pain into the neuropathic pain framework. As new studies cite older research, confusion about the definitions and boundaries of pain types has grown. The term neuropathic pain may refer to different concepts depending on when and how it was used. This makes it difficult to interpret prevalence, diagnosis, and treatment data across studies. The resulting academic uncertainty can have real-world consequences for patient care and research progress. To address these challenges, a new proposal suggests integrating nociplastic pain into the neuropathic pain framework. This would mean using the term neuropathic pain to encompass both traditional neuropathic and nociplastic pain. Alternatively, nociplastic pain could be classified as a subcategory of neuropathic pain. The goal is to simplify diagnosis and treatment, reduce academic confusion, and improve patient care. Or provisional plans have been proposed to guide the integration of nociplastic pain into the neuropathic pain framework. 1. Integrate MPP into NEP and use the term NEP. 2. Classify MPP as a subcategory of NEP and use the term NEP. 3. Integrate MPP into NEP and use the term new NEP and NEP. 4. Classify MPP as a subcategory of NEP and use the term NEP. The recommended approach is the first. Fully integrate NPP into NEP and use the term NEP. Integrating nociplastic pain into neuropathic pain offers several benefits. It simplifies the diagnostic framework, making it easier for non-specialist clinicians to provide effective care. It also allows for the sharing of research findings and treatment strategies across conditions, potentially improving outcomes for patients. By reducing academic and clinical confusion, this approach could accelerate progress in both research and practice. Proposed integration also has implications for the concept of psychogenic pain. The term psychogenic pain is still occasionally used, sometimes interchangeably with nociplastic pain. However, the IASB definition of nociplastic pain does not include psychogenic elements. By unifying pain categories, the use of the term psychogenic pain may decline, reducing stigma and improving access to appropriate care for patients. Historically, pain research has focused on nociceptive mechanisms, with neuropathic pain research centered on peripheral nerves. As pure nociceptive pain becomes less common in chronic conditions, research is shifting toward central mechanisms. Integrating nociplastic pain into neuropathic pain may focus future research on central neuropathic mechanisms, with fibromyalgia recognized as a prototypical central neuropathic pain condition. With the proposed integration, pain could be classified into 3 main clinical categories: pure nociceptive pain, pure neuropathic pain including former nociplastic pain, and mixed pain involving both mechanisms. This simplified framework is designed to make diagnosis and treatment planning clearer, especially for clinicians who do not specialize in pain management. Acute pain, pure nociceptive pain is relatively common. However, as pain becomes chronic, repeated stimulation of the nervous system reduces the prevalence of pure nociceptive pain. Chronic pain is more likely to involve neuropathic or mixed mechanisms. This shift underscores the importance of focusing on neuropathic and central mechanisms in chronic pain management. Some experts argue that nociplastic pain provides a valuable explanation for pain without known pathology. However, similar concepts like central sensitization and unexplained central neuropathic pain can also account for these cases. The proposed integration does not dismiss the reality of these pain experiences, but seeks to streamline terminology and improve clinical utility. Proponents of nociplastic pain argue that it helps patients understand their pain and guides treatment. However, the lack of clear diagnostic and therapeutic distinctions limits its practical value. Integrating nociplastic pain into neuropathic pain may provide a more actionable framework for both clinicians and patients. The concept of nociplastic pain faces several critical challenges: lack of reliable diagnostic methods, overlap with neuropathic pain, inconsistent use of terminology, and absence of specific treatments. These issues complicate both research and clinical practice, making it difficult to provide clear guidance for patient care. For clinicians, the integration of nociplastic pain into neuropathic pain could simplify decision-making and improve care. By focusing on shared mechanisms and treatments, clinicians can provide more consistent and effective management for patients with chronic pain, regardless of the specific label applied. For researchers, a unified pain classification system could facilitate the comparison of studies and the development of new treatments. By reducing conceptual confusion, research findings can be more easily translated into clinical practice, ultimately benefiting patients. Patients stand to benefit from a more straightforward classification system. Simplified diagnosis and treatment strategies can lead to faster, more effective care. Reducing the use of stigmatizing terms like psychogenic pain can also improve the patient experience and encourage more people to seek help for chronic pain. Despite the proposed integration, many questions remain. How can we develop better diagnostic tools for chronic pain? What are the most effective treatments for overlapping pain mechanisms? Ongoing research and collaboration between clinicians, researchers, and patients will be essential to address these challenges. Summary: the distinction between nociplastic and neuropathic pain is often blurred in clinical practice. Both share many features and respond to similar treatments. Integrating nociplastic pain into the neuropathic pain framework may simplify diagnosis, reduce confusion, and improve care for patients with chronic pain. As our understanding of pain continues to evolve, so too must our approaches to classification and treatment. This work acknowledges the contributions of many researchers and clinicians in the field of pain medicine. Special thanks are given to those who have advanced our understanding of pain mechanisms and to the patients whose experiences drive ongoing research and innovation. The development of this proposal involved extensive literature review, data analysis, and conceptual work. The author was responsible for all aspects of the research and manuscript preparation, with support from AI tools for language refinement and organization. No financial support was received for this research, and there are no conflicts of interest to declare. The findings and recommendations presented are solely those of the author, reflecting an independent and unbiased perspective. Generative AI tools, including ChatGPT, were used to refine the language and structure of this manuscript. The final content reflects the author's own revisions and responsibility for accuracy and style. The views expressed in this work are those of the author and do not necessarily represent those of affiliated organizations or the publisher. Any products or treatments mentioned are not endorsed by the publisher. For those interested in exploring this topic further, a comprehensive list of references is provided. These include foundational papers on pain classification, diagnostic tools, and treatment strategies, as well as recent research on the integration of pain mechanisms. As pain research continues to advance, new diagnostic technologies and treatment options will emerge. The integration of nociplastic and neuropathic pain is just one step toward a more unified and effective approach to pain management. Ongoing collaboration and innovation will be essential to meet the needs of patients worldwide. The main takeaway from this proposal is the importance of simplifying pain classification to improve clinical care and research. By integrating nociplastic pain into the neuropathic pain framework, we can reduce confusion, streamline treatment, and ultimately provide better outcomes for patients with chronic pain. Pain is a complex and deeply personal experience. As our understanding of its mechanisms grows, so too must our willingness to adapt our frameworks and approaches. By embracing integration and simplification, we can better serve both patients and the broader medical community. Thank you for joining us on this journey through the evolving landscape of pain classification. We hope this overview has provided valuable insights into the challenges and opportunities facing clinicians, researchers, and patients alike. Stay tuned for more updates as the field of pain medicine continues to advance.